Hello, my name is Jacob Stevens, and I'll be presenting our study entitled Outpatient Electrofulguration for Antibiotic-Recalcitrant Recurrent UTIs in Women with Trigonitis Alone. We have no disclosures. Recurrent UTIs are typically defined as greater than 3 per year, and typical treatment, as suggested by the recent guidelines in JU 2019, recommend vaginal systemic estrogen, postcoital or self-start antibiotics, or a continuous suppressive antibiotic regimen. This antibiotic-heavy regimens leads to antibiotic resistance and allergies, particularly in older patients. Many of these women have been found on cystoscopy to have areas in their bladder of chronic inflammation, noted as trigonitis when isolated to the trigone. A recent study by Endoscopic et al. Actually found areas of bacterial presence in these areas of chronic inflammation, suggesting that they harbor bacteria in these areas with a potentially protective biofilm, leading to antibiotic resistance. One option to eliminate these areas of chronic inflammation is electrofulguration. In a previous study at our institution looking at women with lesions in all areas of the bladder, we saw a 75% resolution of lesions at the 6-month follow-up cystoscopy and an overall 80% improvement in UTI rates. The aim of our study was to evaluate endoscopic and clinical outcomes of women treated with electrofulguration for antibiotic-recalcitrant, uncomplicated recurrent UTIs with documented trigonitis alone, as we believe women in this group will fare best. We performed an IRB-approved study looking at women since 2008 with uncomplicated recurrent UTIs documented by cultures or referral from other MDs. All women were over 18 and had negative urologic evaluations. They all underwent office cystoscopy that demonstrated lesions confined to the trigone, and they all had UTIs defined as antibiotic resistance greater than 3 classes, allergies to greater than 3 antibiotics, and/or no durable response to long-term suppression. They were excluded if they had any other procedure at the time of fulguration, or if they did not have a 6-month post-fulguration cystoscopy or less than 12 months of overall follow-up. For each patient, we looked at demographics, information about the fulguration procedure, pre- and post-fulguration UTI management, 6-month post-fulguration cystoscopy findings, post-fulguration UTIs based on cultures and/or UTI-like symptoms with an antibiotic course, and we looked at all data up until their last follow-up visit. Statistics used were descriptive, using Fisher's exact for categorical variables, and student t-test and ANOVA for continuous variables. Fulguration was performed using a 17.5 French erythrocystoscope with a fine-tip monopolar Bugbee electrode on a setting of 20 to superficially fulgurate the lesions. The upper left image shows an example of trigonitis with cystitis cystica, pus pockets, and tiny encrusted areas in a woman with recurrent UTIs. The upper right image shows an example after fulguration what the trigone can look like. And the bottom image shows an example of a healed trigone at 6-month follow-up cystoscopy, which all patients undergo to make sure that they've developed no new lesions and to make sure that they've fully healed. A primary outcome was number of UTI episodes per year starting after the 6-month follow-up cystoscopy. Women were considered cured if they had 0 UTIs per year, improved if less than 3, and failed if greater than 3 per year. Secondary outcome looked at the endoscopic results of their 6-month post-fulguration cystoscopy, with success considered if they had complete resolution of the trigonal lesions and no new lesions elsewhere, and failure if they did not have complete resolution of the trigone lesions or new lesions elsewhere in the bladder. Overall, 40 women met study criteria. This table shows the demographics of the patients based on endoscopic success or failure. There were no difference in demographics between the two groups, and both groups had long-term follow-up, as seen in the table on the right. There were also short operative times in both groups with a median of 17.5 minutes, with almost all operations taking less than 25. We also noted no post-fulguration complications, supporting the safety of the procedure. This next table shows the post-fulguration results based on endoscopic success or failure. Overall, 85% of patients had endoscopic success, with only 15% still having lesions in the bladder. Looking at clinical outcomes, 23% of patients had no UTIs in the follow-up period, and 73% had an improvement in their UTIs over the follow-up period. Only 2 patients underwent repeat fulguration, and both of these were for lesions that developed in new areas of the bladder over time. It's also important to note that no patients were on suppressive antibiotics in the follow-up period. Since the clinically improved group was the largest group of our results, we broke it down further by less than 1 UTI per year, 1 to 2 UTIs per year, and 2 to 3 UTIs per year. And we discovered that 2/3 of patients actually had less than 1 UTI per year in the improved group. We also noted there was an older age in the group of patients with 1 to 2 UTIs per year, as well as increased use of self-start antibiotics in the patients that had 2 to 3 UTIs per year, which makes sense based on their increased UTIs. Electrofulguration is a short, minimally invasive procedure with low risk of complications. We saw a high level of endoscopic success and even higher level of clinical improvement or cure. In conclusion, electrofulguration may provide alternative treatment for antibiotic-recalcitrant recurrent UTIs secondary to trigonitis. The role of fulguration warrants further investigation in prospective studies. Thank you.